I want to welcome everyone to the third webinar organized by NASMEC this year. This webinar was supposed to have happened on the 27th of May, but because of some unavoidable circumstances, we pushed it to today. We'll be having quite a number of them coming up. We'll be having a COVID. Shall be having a COVID webinar coming up next week, and then we'll continue with the rest of the program. So today we are privileged to have a team from Gulu, sub-region, discuss and share with us information and evidence-based practices regarding sickle cell disease and pregnancy, how to manage that, and the subsequent outcomes. The session is going to be coordinated, or rather moderated, by Dr. Baifa. Dr. Baifa has been a very strong member of the NASMEC. She's been contributing a lot of guidance and information, and today we'll be privileged to have her moderate this session. She's an obstetrician and gynecologist at the Gulu Regional Referral Hospital. I'm sure she would say a lot more other things about herself, but at this point in time, I will be able to hand over to her. Just before she comes, our ground rules are the same, they never change. Ensure that at all times your audio is muted, your microphone should be muted unless you have been asked to talk. And number two, if you have a question or a comment, feel free to use the chat. We have a group of specialists and members who will be able to give you feedback besides the presenters. The third ground rule is to make sure that at all times your videos are off, because they tend to distract the presenters. Only the presenters' videos are allowed to operate. At the end of the session, we'll have a post-test question or a post-test for all the members. This is to check understanding, but also to help us improve these webinars. So with those very many remarks, I want to hand over the session to Dr. Baifa, who is going to take us up to the end of the session. We'll come back again later to close the session. Dr. Baifa, the floor is yours.
Okay, thank you very much, Dr. Elado. Dear members, a very good afternoon to all of you. I'm Dr. Baifa Arwinyo, and I'm an obstetrician at Gulu Regional Referral Hospital. And we are privileged as a sub-region to host the webinar series for today on management of sickle cell in pregnancy. We have a cross-section of panelists for our today's discussion. So the institutions that are I won't take part in today's webinar is we have a presentation from Gulu Regional Referral Hospital, Gulu University, and St. Mary's Hospital, Lacho. So among the presenters, we have myself as the moderator of today's session, and then we have Dr. Oscar Ocaya. Dr. Oscar Ocaya is a senior medical officer at St. Mary's Hospital, Lacho. Previous slide, please, at St. Mary's Hospital, Lacho. And he will take us through a case presentation of a case of a sickle cell case that was managed by Lacho Hospital. And then after his case presentation, we shall go in depth into the management aspects of sickle cell disease in pregnancy. We shall have Dr. Sunde Ojara, who is an obstetrician gynecologist based at St. Mary's Hospital, Lacho. He will take us through the role of other stakeholders in the management of sickle cell disease in pregnancy. This will be facilitated by Dr. Stephen Baguma, a medical officer from Gulu Regional Referral Hospital, and Dr. Francis Pebolo will crown it up with the other blood disorders of relevance in pregnancy. Dr. Francis Pebalo is a lecturer in the Department of Reproductive Health, Gulu Regional Referral Hospital. This is a couple of brilliant young practitioners who will be able to share with us the experiences in the management of sickle cell disease in pregnancy. Next slide, please. Next slide. Team Lacho, next slide. Team, next slide. Okay, so like I mentioned earlier, we shall have an overview of sickle cell disease in pregnancy. I believe we are all well aware of sickle cell as in the fact of the word, but today we want to focus on sickle cell disease in pregnancy. When we talk of sickle cell disease, what do we mean? When we talk of sickle cell trait, what do we mean? When we talk of sickle cell anemia, what do we mean? So we hope to have all this clear in today's webinar. So when we talk of sickle cell disease in brief introduction, sickle cell disease is basically a disorder which is hereditary. So it involves having presence of abnormal hemoglobin S in the beta chain of hemoglobin. So this might be recessive or dominantly inherited by an individual. So when it is dominant, then we say someone has sickle cell disorder, where we have both beta chains having the abnormal hemoglobin S. So such people always will have sickle cell disease, or they may present with sickle cell anemia. However, those that have got the sickle cell trait, it is recessive in nature, where there is only one of the beta chains having the abnormal hemoglobin S. So these individuals will carry the genes, but they may not present with a disease. However, if they got partners with the same, they can produce children that have got the dominant. So, and then we also want to appreciate sickle cell anemia. Sickle cell anemia is, we're basically looking at shortage of blood, low blood levels in an individual with the sickle cell disorder. So those are the key differences between the three different terminologies that we are going to be coming across, and they will be elaborated more as we go on. So in the first slide, next slide, please. We have a brief introduction and the background of Acholi sub-region. I do not want to believe that it's very clear to all of us. Acholi sub-region. Acholi sub-region is located in northern Uganda, as we can see the map. We have a total of 7 districts in the sub-region and 1 city. We are very proud of that. So you can appreciate Lamour far in the north. We have a Muru district, Noya, where Naka Hospital sits. We have Gulu, where Gulu Regional Referral, Lacho sits, and Gulu City itself. And then we have Omoro district, where we have La Logi Health Center 4. We have Padel district, which houses Pajule Health Center 4 as a CMOC site. And then we have Agago district. Agago houses Ambrosoli Hospital, Kalongo, the famous Kalongo that members have heard of. And then we have Kitgum district. Kitgum houses St. Joseph's Hospital, which is the PNFP, and Kitgum General Hospital. And then Namukora Health Center 4. Those are the major facilities in those districts. And finally, Lamour is a district that houses a big number of refugee population. And it has got 2 health center 4s, Padibe and Madiope health center 4s, that are high volume in that region. So our population as a sub-region is about 1.5 million people. We also have a good number of refugee population of about 40,000. So, and the majority are settled in Lamour district, and this causes a burden on the health services provided by the team in Lamour district. We have a total of about 315 health facilities spread across Acholi sub-region, with Gulu Regional Referral as the only regional referral in the sub-region. And then we have 7 general hospitals, to include St. Mary's Hospital, Acho, 8 health center 4s, 74 health center 3s, and the rest are health center 2s and private for-profit clinics across the region. To be specific to sickle cell disease in Acholi sub-region, unfortunately, the DHIS2 does not provide specific data on sickle cell disease in pregnancy from the antenatal clinic or from data of deliveries across the facilities. The information that we shall provide in the next slide is basically the patients we've been able to see as extracted from the primary registers from antenatal clinics of Lacor and Gulu regional referral. To appreciate that sickle cell disease has remained one of the commonest disorder that is heredited worldwide, with over 80% of sickle cell cases in sub-Saharan Africa. And in Uganda, we see an average of about 15,000 to 20,000 children born with sickle cell disease. That poses a prevalence of about 0.8%. So children, we want to believe they are born to mothers who are having sickle cell traits or sickle cell disease. And we also want to appreciate that sickle cell disease is one of the causes of mortality among children under 5. So if we are able to grasp the knowledge and the skill of managing mothers with sickle cell disease or sickle cell traits or sickle cell anemia, we shall be able to reduce morbidity and mortality for both the pregnant woman and her unborn baby. So that slide that you see is showing us the burden handled by Lacor and Gulu Regional Referral Hospital. As you can see, the trend of admission for sickle cell from 2015 to 2020 for Lacor, the numbers are not so big, but then we want to see that the ones that come under our care get quality of care, and then we're able to also identify them from the population. As Gulu Regional Referral Hospital, only 5 cases were seen the whole of last year, but I want to believe there are more than that. So we think we are missing out on some of these cases of mothers that come with sickle cell disease in pregnancy. That is, in brief, an introduction, an overview of sickle cell disease in pregnancy that we are going to look at today. So I want to hand us over to the next presenter to take us through a case of a mother with sickle cell disease that was successfully managed in St. Mary's Hospital at Cho. Dr. Oscar Ocaya, over to you with the case presentation. Dr. Oscar Ocaya, over to you. Dr. Oscar Ocaya, over to you.
Yes. Thank you so much, Dr. Baifa. So briefly, to start this discussion, I'll give you one of the case that we managed from Lacor Hospital. Like she said, these patients are very rare to get. We don't know where that comes from. Is it from maybe the numbers that are few in the communities, or the patients are not captured well from antenatal? So this is a case of AI. She was a 22-year-old female. She was a prime gravida at 35 weeks of amenorrhea. She's a non-sickle cell disease patient on routine prophylactic medications with complaints of generalized body swellings, severe frontal headaches, and epigastric pains for 4 days. She had reported no blurring of visions, no convulsions, no body pains, no difficulty in breathing, no fevers. She attended her ANC from Marcia 4 times, started at 4 weeks of amenorrhea with a normal blood pressure. The baseline HB was 9.3 grams per deciliter. She was HIV negative, blood group O. So with this pregnancy that she was carrying, she had 6 hospital admissions, majorly due to severe anemia and vaso-occlusive crisis, of which she also received on several occasions blood transfusions. Previously, she was on hydroxyurea, but this was discontinued even before pregnancy, since it was not helping with the number of hospital admissions and the vaso-occlusive crisis she was getting while on the medication. Had splenectomy done at the age of 16 years due to hypersplenism. So briefly on physical exam, she was a sick patient with anasaka, with moderate pallor and jaundice. She was a febrile, temperature was 36.7. Obstetric exam, she was, had grossly distended abdomen with bulging flanks. She was at 33 weeks, cephalic longitudinal line, had a distant fetal heart, which was hard and regular at 132. No uterine contraction was felt. Vaginal exam was not done. However, CVS had warm peripheries. She was hypertensive. The blood pressure of 186 out of 124 millimeters of mercury. With a tachycardia of 106. Affect bit was not displaced. Had sounds 1 and 2 with no added sounds heard. Respiratory system was not in distress. With a respiratory rate of 18 breaths per minute, had bilateral vesicular breath sounds. CNS was fully conscious with a GCS of 15 out of 15. Pupils were equal and reactive to light with no focal neurology. Our diagnosis is prime gravida with sickle cell disease and preeclampsia with severe features. Our immediate differentials there could be sickle cell disease associated nephropathy, which still can present with the features that she had come with. Our management plan was to admit on ward to control the blood pressure, and then we do the investigations. The blood pressures were controlled by IV hydralazine, and then we gave our IV magnesium sulfate, and then the investigations which are done at admissions. We did CBC, RFTs, and LFTs to look at the organ function, and obstetric ultrasound to look at the fetal status, the physical profile, urine dipstick, actually for protein, and then grouping and cross-matching. Being a sickler, you have to be prepared for blood transfusion at any one time. So the results that we had, protein urine dipstick is an immediate investigation that can be done on the spot. Protein was 3 pluses, however, leukocytes and nitrates were negative. CBC had thrombocytopenia with a moderate anemia with an HB of 9.2 grams per deciliter. RFTs, as you can see, creatinine and urea were all elevated.
Dr. Chaya, can I interrupt you a bit?
Enzymes were elevated.
Dr. Chaya?
Obstetric ultrasound showed a single intrauterine pregnancy at 30 weeks of amenorrhea.
Hello, Dr. Chaya?
Estimated of 1.4 kilograms.
Hello, Dr. Chaya, can I interrupt the team in Lacho briefly?
Yes, please.
Your audio is not very clear and we are getting echoes from another source. So looks like 2 gadgets have been logged in at the same time. Could we make the audio clearer? Thank you.
Continue. Referrals. Continue. Sorry for the interruption.
sorry for the interferences. I don't know now where exactly I should even start from. Maybe I'll just now be fast and then I start afresh. Will that be okay?
No, I think you can start from where you stopped. Members following just that there were interferences.
Oh, okay.
Yeah.
Yeah. So I was already at the postpartum.
Yes, that audio is better. Thank you.
So I was saying the patient was admitted, the blood pressure was controlled after 12 hours with a decision to do a cesarean section and a bilateral.
We can't see your screen.
The screen is there.
The screen is there.
Okay. Sorry, I think the fault. Thank you. Continue.
Right. So I was saying the blood pressures were controlled after 12 hours with a plan to do cesarean section and bilateral tubal ligation. This was done and an alive baby boy was delivered with a weight of 1.4 and scored 89. Later, the baby was admitted to nursery ward. So the pain management was by IV morphine, and then we kept her on maintenance magnesium sulfate for 24 hours. Then we switched her to oral antihypertensives, nifedipine and methyl dopa with a low dose IV fluid of 1.5 liters in 24 hours. Patient was discharged later on from the ward after 5 days on routine prophylactic regimen and oral antibiotics for 5 days. Later on, the baby was also discharged after 2 weeks from nursery. Currently, as we speak, all of them are in good health conditions. Thank you so much. That was a brief case discussion, case presentation that I had prepared.
Thank you very much, Dr. Chaya, for that case presentation, and thank you for correcting the quality of the audio. There have been a couple of questions in the chats. I thought we would address them, especially since it was a case presentation that was done. We had a question from one of the participants, Dr. GRRH, was asking at what age was this mother diagnosed with sickle cell disease in her life? And then the next question was, what do you mean by nursery ward in the Cho hospital? And one of the slides stated that the mother was delivered by cesarean section plus BTL. We thought it was a prime gravida. Would you kindly address those, then we move on? Dr. Chaya, over to you.
Nursery, this is an intensive care unit where we admit and we monitor. Now for this case, for our case, this was a case of a very low birth weight, and prematurity. That's why we had admitted her, the baby there for management. And then the next question was, at what age was the patient diagnosed with sickle cell disease? The patient was diagnosed with sickle cell disease at the age of, she was 5 years. And
At 5 years, okay.
yes, then the other question was,
the other question is, why did we do a BTL for this mother?
a BTL was the patient's choice. It was typically, it was her choice.
Okay, I think we shall discuss more on that at the question and answer session. Would love to appreciate more on the patient has chosen. She's a para 1 with a very low birth weight baby whose chances of survival in our country is not very high versus what the clinician thinks for her age and her parity. So you can keep pondering about that. We shall have more discussion at the end. What is our role as the clinicians here if the patient thinks so? Yeah, okay, so that was the case of sickle cell disease in pregnancy. You can keep sharing your questions on the chats. We shall relay them to the respective participants. I would like us to move on to the next presenter, Dr. Sunde Ojara, who is going to take us through
Thank you, Dr.
management.
Baifa.
Yes, yes.
I hope I'm loud and clear.
Not very. Make it better.
Okay. In the presentation, we are looking at the management of a mother who has a sickle cell disease. And the core that we are reviewing here is looking at the prevention and then how we can promote treatment. Now, core to the management plan that we need to do for all mothers who have sickle cell disease, one is having a preconception counseling, having a pre-pregnancy evaluation, and then good antenatal care, intrapartum care, postpartum care, and management of specific complication, and follow-up and linkage into the community. And then also we should be in position to have prevention and health education. When you look around the case that Dr. Oscar's presented, it almost summarizes our presentation. And key to this is before anyone intend to have a pregnancy, we must as physicians ensure that there's preconceptional assessment and counseling. And this is very important in making the decision. Like you saw in the case that Oscar presented, the mother at the end made her own choice of doing a BTL. So having a referral to genetic counselor are quite a good recommendation that we should empower our patient. And then also having basic information that we give to them that empowers them. So among us, some of the genetic counseling that we need to offer, because it's the choice of the mother and the couple to understand what risk potentially pregnancy can have. And you know that a mother who has sickle cell disease has a number of complications that they can develop. Among them, very commonly we see, if you saw in the Lacor data, most of those who are admitted actually presented with sickle cell anemia. Now, in the community, we are wondering, because in northern Uganda, we know for sure that this is one of the disease burden area. We only see very few cases. Where do these people deliver from? And this is a choice where we have to talk to them. So the use of donor sperm, where it's from both couples, they will probably get the one that has no hemoglobinopathy, and that can be inseminated using the IVF. And then we can also have pre-implantation genetic diagnosis. That's the offer that is being prepared during the IVF. We get the one that has no hemoglobinopathies. Or we may also have a gestational carrier pregnancy, someone who prepares for these couples and then carry on with this pregnancy. Now, the traditional surrogate mother, she must be someone who is having negative sickle cell disease so that she can carry for this couple the newborn that is going to be. Or the option could be adoption. So these mothers who intend to have children, if situation become that they have now end organ damage, option can be adoption, and that's something that can be taken. Now, in other countries, there are prenatal diagnosis and termination, where they do an abortion. In this country, this is odd, and we practically may not go for that. But as you move around the world, this happens in selected cases. If a mother finds that the particular pregnancy is carrying, she's a right to terminate it, and that's where the law of the country governs. Now, very important to empower someone and give an information, and that's why knowing who is the partner's hemoglobin status is very important. If it's a carrier or it's a sickler, you know the likelihood of the newborn that will be. If it's homozygous or heterozygous, what are the likely risk and chance in this growing a child that will be in the future? So this will guide on discussion for both couples when they're choosing correctly during that time. And then the risk that pregnancy will carry. This risk goes both to the mother, and the risk also goes to the fetus. So it's very important to educate them and they understand the consequence, what pregnancy can carry, and what pregnancy can induce when someone has sickle cell disease. Now, the availability of a reproductive option, like you have said, there are so many around the world, and even in this country, Uganda is no longer a small country. We now have advancement in technology, so we should be embracing some of this and we empower them so that they have this preconceptional counseling before someone chooses that this is what I want to do. And once that is done, then we must confirm correctly the diagnosis. And basic that is common around the country, we do the sickling test. If the sickling test is positive, then you go ahead and then you do HB electrophoresis. HB electrophoresis will now give you the rates of the finding whether there is high percentage for someone who is carrying complete hemoglobin S homozygous or is a carrier, so that can give clearly what it is. And then also knowing the paternal status, whether it's a carrier or a homozygous, because that will guide us in knowing the offspring. So during your pre-pregnancy evaluation that you encounter with a woman who is intending to have a pregnancy, it's very important to have detailed history. If she's already a non-sickler, her previous episodes of painful event or occlusive crisis or an hospitalization, blood transfusion, you must get those accounts so that it guides your management of this mother throughout the course of her pregnancy. And then you should also end up going to evaluate for certain detailed organ damage. Taking her blood pressure, baseline, booking BP is very important. And here they're at risk of superimposed preeclampsia. And you know that with sickle cell disease, risk of nephropathy comes in. So knowing this patient is very important. And then going ahead also to evaluate them for retinal proliferative sickle cell disease, taking a 25 urine protein, urea creatinine clearance, that will guide us. Now, each of the women that is intending to have this pregnancy, you do pre-pregnancy evaluation on HB. You want to know what is the hemoglobin status. Someone probably could have been having chronic anemia. You have to optimize them before they conceive. And when someone has a low HB, likely they can also end up with failure to conceive, and issues of infertility comes in. Now, you also want to discuss what is the iron load in the blood. If she has already iron overload, probably this is not a candidate rightly enough that you want to start on ferrous sulfate. And that's something that you must take it into account. Now, we know that someone who has sickle cell disease, they're at risk of the bacterial infection, and doing a baseline urine culture would be scientifically good enough to back your planning for her pregnancy. And also for those who have had a number of complications, reviewing on their chest symptoms during this corona pandemic, a mother who may present with acute chest syndrome may likely also behave like someone who has a sickle cell disease. And knowing about the status of hepatitis B and hepatitis C is very important, as liver disease can be part of this. So when you've done all that in your pre-evaluation, which can be at L Center 2, can be at L Center, it can be at L Center 2, it can be at L Center 3, or in a clinic. Key to antenatal care aspect comes in that
Ojara.
this is not one person work. It's a multidisciplinary. We involve the physician, we involve the midwife, and we, the obstetricians, that we become part of the team in the care of this mother. So you must not take it that when you're caring for a mother who has sickle cell disease, you need team to be part of you so that you involve in addressing particular key areas. Now, there may be also risk for end organ damage, so you need to make early referral so that they are seen. If someone has already nephropathy, or maybe she has already retinal proliferation, you need to refer them appropriately on time without wasting time. And then we must also avoid factors that bring them exacerbation of symptoms. Things like dehydration, overexertion, these mothers should be avoided from having those. And control of nausea and vomiting, very important. Earlier, as you start planning for antenatal, you must work up this, whether you're going to give them vomit sticks, or you're going to use home remedy, like using garlics, or maybe avoiding a particular food that she doesn't like. It's very important that you address and handle this. And of course, in the country, we have already immunization program that is ongoing. We believe that the girl child is fully immunized, and this can enhance them from being prevented getting some of those encapsulated organisms like the influenza B and then pneumococcus pneumonia. So vaccination is very important. Now, core in the package that every woman who attends antenatal clinic and she has sickle cell disease is inform them, give them right education about what problem they are having. Let it be basic in the low language that they understand the risk they're carrying. And that's why in the case Oscar presented, this was a young girl that's been frequenting the hospital. I think I've known that girl since I joined medicine over 15 years ago, that she comes to the hospital and gets frequent blood transfusion. So when you have a case like that that is followed up, it's very important to empower them so that they know their own status. And during this COVID time where blood transfusion is a problem, these are people that they know their risk and they know that when this happens, I can likely run for this. And improving nutritional status, you know that with sickle cell anemia, micronutrient deficiency is among some of the hard problem that they do have. So we need to improve and also try to advise the community and the family on the right food that they take in. Early detection of bacterial infection, control of malaria, this become hallmark of antenatal package that we have to work through. And then in case these mothers come and clinically you found such a sickle cell disease and some of the screening process have not yet been done, you go ahead and do the evaluation and you do your confirmation. And of course, having a monthly HB check, urine protein and creatinine is very important in this case. Now,
hello, Dr. Ojara.
Yes, please.
Hello.
Hello.
There is a complaint in the chat that you need to up your volume a bit. Increase the volume. Thank you.
Thank you. In terms of the medication.
Okay, that is worse. Get it better.
In terms of the medication.
Yeah, that's great.
Is that better?
Very well.
In terms of medication, of course, you have to be selective on knowing what to give. Please, could you take me back to the next slide, the first slide?
Members, please mute yourselves. I see Dr. Francis is on. Samuel, please mute yourselves. Thank you.
Oscar, the first slide up. So we have to guide them on medication that they have to take. So preconception folic acid is ideal for them. And other protocol talk about antibiotic prophylaxis. Now in the UK, they give to every woman who is pregnant antibiotic cover, but this is not in every protocol. When you look around the American Society of Sickle Cell Association, they don't have this. And then in Uganda here, we don't have a very clear protocol on the antibiotic prophylactic. However, in children, this has been given. Maybe this is subject for discussion. Now, drugs that are unsafe should also be stopped. If a mother has been hydroxyurea, you have to pull out 3 months before she she conceive. And then also those who probably have iron overload, the escalators, you have also to withdraw it out. And then those who have AC inhibitors, you know that these are not good in pregnancy, you have to stop them. And then there are particular drugs that also of concern that you need to take note, like labetalol. Labetalol is associated with hepatotoxicity, so it should be avoided in someone who have liver disease. And these are common thing with sickle cell disease. Now, a mother who may be having preeclampsia and you would wish to give her metal dopa. Now, it will be very difficult for you to know whether the hemolytic anemia is due to blood transfusion because they tend to react to CUM positives. So this will complicate our management. So you have to take some caution when you are dealing with this particular case. Oscar. Now, in pain control, we use the WHO ladder where we have mild, moderate, or severe. So most cases, if the pain is mild, we can use the acetaminophen, the paracetamol that is commonly we use, or if it's moderate pain, then we can use the codeine sulfate, and we can combine still also with acetaminophen, or even we use some of the non-medical ways of putting on warm stockinette. And if the pain is severe, then we can use opioid. Now, very important in close monitoring for development of preeclampsia, you have to be taking the blood pressure. And we can also do this in a already a proven study, which says when you give a woman aspirin 75 milligram daily, at least up to from 12 weeks onward, it tries to reduce the risk of development of preeclampsia. So this is something that we can employ in terms of medication. And then for all patients that we hospitalize them, we need to know that pregnancy and sickle cell, there's added risk of development of venous thromboembolism. So giving them low molecular weight heparin for someone that you think you're going to keep her long in the hospital, it would be of importance. Next slide, please. Now, additional to that, we also need to do blood pressure monitoring, which is routinely, and if possible, this matter should actually be done on a daily basis. But of course, in facility where it's not possible, monthly as she comes to antenatal care, we must pay special attention that her blood pressure is taken, not something that is recorded. I remember one time when we were in a community health center in Kasese, we look at the record book. Actually, there was no blood pressure being taken in a health center too, and the blood pressure was actually not in function. So ensuring that all the service points at your unit have working blood pressure is very important. And then urine analysis midstream, perfect for excluding for any possible infection. Now, recommendation for ultrasound, this one adapted from the UK guideline. They take the viability scan between 7 to 9 weeks to confirm that there's live intrauterine gestation, and then your routine scan after first trimester, which is between 11 to 14 weeks. And then for any anomaly, then we work it out. Then routinely we do a serious scan from 24 up to 38 weeks so that you can exclude any risk of development of intrauterine growth restriction. Now, blood transfusion during pregnancy is life-saving, but it is not routinely recommended as a prophylactic. So you'll only give it when it's indicated. For someone who probably got an acute chest syndrome, or maybe someone who have had a painful crisis and maybe their blood is low, then you necessitate to transfuse them. But you have to be careful that blood transfusion given to mothers who have sickle cell disease, there are also other ratios typing which we don't have in the country, like for C, D, E, and the K typing. So it's very important that you know that the allo immunization can happen during transfusion. And of course, the blood must be safe. If you infuse the sickle with a blood that contains some of the virus like cytomegalovirus, you're going to worsen their plastic anemia. For intrapartum care, spontaneous labor and vaginal delivery is best desired. So there's no need of risking the mother for any induction in any case. So unless there's a clear obstetric indication that you may plan for cesarean delivery. So normally allow them to go to labor, at appropriate gestation age term, and then you deliver them. And if there's another problem during that time in labor, try as much as possible to give them good hydration and put them on oxygen so that they don't get into painful crisis. And don't forget with fetal monitoring. Now in facility where they have anesthesiologists, they can control their pain by giving the neuroblockade. Now, whether to deliver by elective Caesar or not, this will also still depend on obstetric indication, not because it's a sickler. And you must optimize your patient that their HB are at least between 10 to 12 to 11 grams per deciliter. And if needs be during the operation, supply them with oxygen. I am proud that the Ministry of Health has at least given most of the cylinders in most of the facilities that are able to operate try as much as possible to put your patient on oxygen. We would prefer using regional anesthesia than general, with bearing in mind that some of the patients may be having chest complication. So you are safer giving a spinal than going to give a general anesthesia. But you have to be careful when you're giving fluid. You know that with a sickle, there's already a cardiac myopathy. So when you infuse them annually, you can have it fluid overload, and then the heart may fail to take that. Now, after delivering of the baby, in countries where they can, this is the time they can harvest some of the blood, and they can make confirmation on the newborn whether she is a sickler or not, or whether it's having a carrier. But of course, they can also do banking up for this harvest for future bone transplant. You know that sickler, we can prevent it, we can manage complication, and we can treat it. There's no cure, so they can do bone marrow transplantation. Now, in the postpartum care, very important is infection prevention and thromboembolism prophylaxis. They are at risk of getting what? Fat and bone embolism. Now, key during the postpartum care, antibiotic prophylaxis guided by the local practice, and adequate hydration, prevention of postoperative nausea and vomiting, and then offering them adequate oxygenation. Now, patients who are delivered by cesarean section, they tend to take more time on bed. Now, better to give them at least low molecular weight heparin to prevent them having the DVTs, compared to someone who have had a normal vaginal delivery. So early ambulation and avoiding of dehydration is a key. Other postpartum care that are of importance, remember that you've stopped this woman from hydroxyurea. Now it is time for you to see, after 3 months, breastfeeding, baby probes cop up, you now need to reintroduce back the hydroxyurea, which is a mainstay. And you know the role of hydroxyurea that has improved life in patients who have sickle cell disease. And then for those who probably had iron overload, this is the time you reintroduce the chelators and then also the ACE inhibitors that give them the nephroprotection. Now, breastfeeding, we also discourage drug that crosses into the breast milk like hydroxyurea. With family planning, WHO says you can use the combined pills, COCs, POPs, or even IUD. But of course, bearing in mind, if you're giving a COC in the postpartum, it must be at appropriate time. And you also have to take note that it can also bring risk with DVT. Now, infant care, we do the routine. No special package until 3 to 4 months, then you do your diagnosis to confirm whether this baby is carrying the homozygous or is a carrier. So this is very important. But of course, now that we are giving morphine for pain control, sometimes they may have opioid withdrawal syndrome. So you have to watch out for that. Management of common complications that do occur in pregnancy, that women who are pregnant will always come with, is pain. So we have to evaluate all women who have sickle cell disease for pain. And we do this concurrently with the midwife and the team. And if you're a midwife in a low facility, please refer them to a tertiary center, maybe someone with a better expert. You may even manage this in your own clinic, but you must be in position to identify someone who has pain. And then you use appropriate analgesic ladder for managing the mild, moderate to severe pain. Betadine, please don't give betadine to someone who is a sickler. The risk is high. Betadine, if you give to someone who's sickler, they are at risk of getting a seizure. And this is because of the norpeptide, the residue of metabolite betadine that tend to irritate the cerebrum. So they tend to end up with seizures. So practically we can use opioid like the morphine, that much better. But if you are stressed to the extreme, then you probably need to confirm that high urine output is good and do well with hydration and oxygenation that need assessment. Now, prophylaxis will continue in all women after delivery. And then pain assessment, very important that the patient doesn't get what? Worsened symptom. For acute therapy for acute chest syndrome, this is life-threatening. And with the current pandemic of COVID-19, you may never know whether you're handling an acute chest syndrome or you're handling a patient who have actual difficult breathing from COVID-19. So you have to be very vigilant, and you do adequate and immediate pain control and fluid management to prevent hypovolemia, and supplementary oxygen. Where your facility are available, you can use incentive like for spirometry. Then blood transfusion remain mainstay, and you also have to treat out the infection, and that's why we can also identify, do a culture to exclude if there are particular infection. Of course, for acute chest syndrome, if you are to take an X-ray of this patient, you are going to find that there's a clear new onset radiodensity opacity in the lung. But of course, clinically, anyone who have difficult breathing in pregnancy, you have to suspect this.
Dr. Ojara, summarize.
Family support, one slide. Continue health education support and information and linkage of sickle cell person to the community or support group. I think in Uganda, there are some organizations that have started this. And in Northern Uganda, we have for children. We are yet to think with Dr. Baifa, and maybe we develop one for the pregnant women. And of course, routine health education. Okay. As I conclude, prevention is more important. Let the patient know a problem, let the family know the problem, and let the community be informed. We should not have stigma. When we have stigma in treating sickle cell disease, that becomes a failure in our success. And then we should also do thorough evaluation of this patient, that they are at risk, we mitigate them, and timely and appropriate treatment of those complications that come in. And where needs be, offer them counseling. We can offer this to our community. And then we need to initiate them also earlier in antenatal care so that we are able to talk to them and identify the likely risk that they have. And some of the prophylaxis, encouraging them with the immunization, that is very important. As I conclude, thank you.
Thank you very much, Dr. Ojara, for that detailed and elaborate presentation on management of sickle cell disease in pregnancy. As you are presenting, there are a couple of questions trickling in from across the country. So I'm going to run through them so you ponder about them, and we move on to the next presenter. Then you're going to have the responses at the end of all the panelists' presentations. So we had questions coming in. You can jot them down in summary so you prepare yourself. We had a question like, how do you do preconception care knowing that most pregnancies, over 80%, are not planned, including those mothers with sickle cell disease? And then the other concern that came in is, okay, someone noted that iron supplementation is not recommended in sickle cell disease. The other concern that came in is, how do you investigate iron overload in a mother with sickle cell disease for fear of how do you investigate iron overload? Okay. And the other concern that came in is, how often should we see a mother with sickle cell disease in the antenatal clinic? Is it monthly, like it is for every mother, or they should be seen more frequently? The other concern that came in is it okay to stop hydroxyurea as soon as you realize the woman is sexually active or when the woman has plans of conception? Kindly differentiate the two. And then the other question that came in is, how long should low molecular weight heparin be given postnatally for prophylaxis against DVT in case it's indicated? When do we stop? And the other query that came in was, what analgesia? I think that has been addressed already by your last slides. And then someone asked from Kasese, what's the maximum amount of IV fluids we should give sickle cell disease mothers on the ward in fear of fluid overload that you mentioned in your presentation? And the other question that came in was, at what point do we resume hydroxyurea postpartum, when you mentioned the fact that it's transmitted through breast milk to the baby? So when do we restart it if we had stopped it? And then lastly, there's an input by Dr. Okumu from Arua Regional Referral Hospital about a new drug, Voxelota. I don't know if I've mentioned it well, which is being used as a direct sickling inhibitor to reduce sickling crisis. Does Acholi sub-region know about this drug? or Dr. Kum is going to elaborate more about it. Thank you. You can ponder about that as we move on to the next presenter, Dr. Baguma, to take us through the role of different stakeholders in management of sickle cell disease in pregnancy. Dr. Baguma, over to you.
Okay, thank you very much, Dr. Baifa. I'm going to be presenting the roles of different stakeholders in the care of sickle cell expectant mothers. Yeah, we would want to state that development of multidisciplinary care or team in management of sickle cell disease pregnant mothers is associated with an improvement in maternal and fetal outcomes. And also, we realize that this establishment of comprehensive sickle cell centers around the country is also associated with better pregnancy outcomes. As you can see, at least all regional referrals and PNFPs have active sickle cell clinics. Also, the initiation of goal-oriented prenatal and antenatal care to include screening and health education, improving nutritional status of mothers, malaria prevention and infection control has also improved and impacted greatly on the
Dr.
mobility.
Baguma, you're breaking.
Sorry, are you getting me clearly now?
Yes, better.
Yeah, it has impacted greatly on the morbidity and mortality of pregnant mothers with sickle cell disease. So among the different stakeholders in sickle cell disease management, we have initially a multidisciplinary team, and these are basically people in a setting of a hospital, where would include a psychosocial counselor, a hematologist, a physician, a general practitioner, a laboratory technician, a midwife, an anesthesiologist, an obstetrician, and a pharmacist, among others. And these usually play an integral role in helping to manage this patient very, very well in the different departments that they handle. For example, the hematologist and the lab technologist in diagnosis, early diagnosis, and also management of thalassemias and any other blood disorders that may be picked on. A physician in management of the illnesses, the crises, or the crisis that may come in the reign, and also any other infections that may be coming in for management. Midwife, pregnancy preparement, assessment, antenatal care, and also identification of any challenges that the mother may have along the going with the pregnancy. The anesthesiologist, this one basically comes in most times when our analgesic ladders have failed, and sometimes you may need to get onto other formalities of management. For example, giving drugs like propofol in managing very, very acute painful crises, or when a mother convulses with something like that. And also during delivery, giving cordal blocks or pudendal blocks for mothers to deliver. And a pharmacist in the medication management and dispensing of hydroxyurea, titering doses for the different age groups and weights. So among the other players, we have majorly the Ministry of Health, and this has ensured functional sickle cell clinics in all regional referrals and private not-for-profit facilities. And also availability of these important medications that these people usually need, providing support supervision and sensitization in the communities about sickle cell disease, and also making sure that the data of these patients that come in every now and then, mostly the children, the pregnant mothers haven't been captured very well, but I think going on forth, we'll get that data coming in based on our recommendations. Other organizations like Uganda Sickle Cell Rescue Foundation, Action Against Sickle Cell Disease, and Sickle Cell Association of Uganda. These are basically organizations that deal with boosting awareness about the disease, soliciting for funds to support the centers that provide care for these pregnant mothers and their children, and also working against stigma within the communities, and also trying to give these patients with sickle cell disease and their children a livelihood and a fair stay within the community, and also equal opportunities. So that's what they usually foster foremost. The downside with these NGOs and other players in this are that they are majorly central and they do not come into the other districts up country to try and have their services decentralized to the communities down this side where people actually need them most. Yeah, so other stakeholders include community members. And in this, we are looking at majorly whether these people actually accept a mother with sickle cell disease or a mother who delivers a child that has sickle cell disease versus stigmatization of these mothers. And usually this has to be countered by very good community sensitization through VHTs that are specific and redirected to sickle cell disease. And also, these actions basically depend mostly on the cultures in different areas and educational backgrounds and basic knowledge about sickle cell disease. And to know that sometimes when this child is, or the mother is diagnosed or delivers a child with sickle cell disease, they can actually grow up to be something or someone of importance in the community with the proper care provided to them. And also to know that if diagnosed early, this condition can actually be given a cap or control not to affect a person significantly so that they can become someone in future. Then the other important stakeholders are the immediate family members and majorly the spouse for support. Because sometimes when mothers are diagnosed, let's say at a certain age, and then they're intending to get pregnant, it takes someone really strong to be supportive and be there for the partner in such times when they get crisis. Because sometimes it can also be costly to manage a sickler or to be with them because they're always in hospitals, and the pregnancy is quite expensive owing to the investigations that need to be done that sometimes are not in the centers where they need them. So someone needs to be really supported. And then the other is a counselor. The counselors they cut across at the community level and both in the and also in the hospitals. And these are basically to provide information and also foster for some semblance of acceptance among families that are in denial about the diagnosis that's made for them. So the process of, we're going to do an audit of intrapartum and postpartum states of a mother with sickle cell disease. So majorly, if you look at labor in a sickler, it's different from labor in a normal mother. Yeah, it requires a thoughtful planning and care and preparation to have this mother delivered successfully. Here we're looking at monitoring the normal process of labor, but also looking out for the risk factors and then complications that may occur, like someone being in a crisis, mimicking labor pains. So you have to be very, very keen to be able to identify, and you need to have the proper clinical and diagnostic skills to be able to identify that. So preconceptionally, we're looking at genetic counseling and testing where these two partners come in and have to be screened, and their outcomes are also supposed to be told to them in a professional way to foster for acceptance if there is a problem, or to allow them make an informed decision about whether they continue with the pregnancy or not, where accepted, and also doing other tests appropriately indicated, and then to look at the different medications that they may be taking if someone is a sickler. We talked about hydroxyurea and that it has to be stopped either before or immediately when someone realizes they are pregnant. And then we talk about timely initiation of ANC. Ideally, we would want to see a sickler have at least two ANC visits within the first trimester. Yeah, and in those ANC visits, Dr. Ojara has shared about what needs to be done. Goal-oriented ANC, and also timely referral and notification of a mother who has sickle cell disease, that she should actually prepare to deliver in a site that can provide the quality of care that she needs, and that is basically a health center 4 and above, where you have a doctor or a huge multidisciplinary team that can manage the complications of such a delivery. And then also follow-up of the mother and baby postnatally and linkage to further care. So during the delivery time, this mother should be in a center that is able and is fully equipped to handle this kind of delivery. As we've talked about it, since this pregnancy is classified under a high-risk pregnancy. So we need to take a note on the hydration status. Dr. Ojara has hinted about this mother shouldn't be dehydrated, and again, shouldn't be overhydrated. She should receive an optimum amount of fluids depending on her hydration status. So the mother should be positioned in a left lateral position in latent labor to avoid issues with hypoperfusion of the fetus. And then also, one should be keen to be able to identify and manage any crisis that might come in that regard. The different crises mothers are prone to during labor is acute chest syndrome, and then vaso-occlusive crisis, most commonly. And also, one should be able to create a disparity between labor pains and the crisis. You shouldn't just look at a mother and say, she's in pain, she's in pain. That's labor. One should be able to identify the differences between a crisis or pain due to a crisis and pain due to labor. Pain due to labor is rhythmic, and it stops at a certain point and resumes. Pain in the crisis doesn't stop unless you give painkillers. So this mother should also have continuous intrapartum monitoring to differentiate contractions from abdominal pain. Yeah, ideally, where possible, the mother should be on a cardiotocogram to be able to identify decelerations and late decelerations, most especially, which would imply fetal distress, and then action taken thereby. So the goals of management of a mother in a crisis is pain control and ensuring proper fetal oxygenation during this crisis. Yeah, and there should be good communication between the team that is managing this patient, and all the decisions that are being taken should be communicated effectively and compassionately. The patient should be psychologically comforted with an improved or better emotional support. Preferably, the caretaker should also be around to try and comfort the patient. Dr. Ojara also talked about the basic investigations that need to be done in the intrapartum period, to include the hematocrit and HB levels, the WBC count, blood slide for malaria, RFTs, LFTs, and also a grouping and cross-match to be prepared just in case of anything, and urine protein. Patients with sickle cell disease in pregnancy are very prone to preeclampsia, majorly due to the fact that they get micro-infarcts due to vaso-occlusion, and this can bring about fetal distress and worsen the outcomes of the pregnancy. And also, they may be susceptible to convulsions in that state, since the micro-infarcts occur generally within the whole body and the brain in that regard. So on pain management, we talked about opioids, safely morphine, and then epidural anesthesia for mothers who are intending to continue delivering, to deliver normally by SVD. And ideally, we talked about the fact that mothers with sickle cell disease should ideally be delivered by SVD unless otherwise indicated. We should aim at ensuring that they deliver by SVD. This is majorly due to the fact that they are non-ambulatory in the post-operative state, which increases their chances of thromboembolism and also those other DVTs and things of the like. So we need to also consider intrapartum oxygenation or monitoring, basically, And where indicated, a mother should be given oxygen by prongs or mask or non-rebreather as the oxygen states dictate. So the delivery plan on reassessment, we could consider induction, augmentation, or cesarean delivery, as will be indicated by the different examination findings that you get. So in the postpartum period, I think Dr. Ojara has mentioned checking for anemia in the mother and then correcting where necessary, teaching breastfeeding techniques, and providing information about compatibility of pain meds with breastfeeding. And also the different medications that are indicated were talked about, and then those that need to be stopped are also talked about. Yeah, we also know that opioids commonly used may cause neonatal sedation. Iron sulfate, and then hydroxyurea. They would be okay with breastfeeding at a later stage. Go on.
Dr. Agoma, summarize.
Yeah, go on. So what can go wrong if we do nothing at all? These mothers are at a higher risk of intrauterine growth restriction and delivery of low birth weight babies, and the risk of miscarriages and IUFBs due to microinfarcts and then hypoxygenation of the fetus, increased risk of low APGAR scores. We talked about a biophysical profile below 6 as an indicator of poor birth outcomes. And also, there is an increased risk of stillbirths, still with the same explanation, and an increased risk of maternal mortality and morbidity due to high risk of infections among these sicklers who have a little bit of immunosuppression, and then transfusion-related problems that have thalassemias, and then preeclamptic toxemia, and then postpartum hemorrhage. And then the other thing that can happen is stigma and discouragement, and then most commonly these people deliver children who, if not managed well, die under the age of 5. That is a huge the challenge that you usually get if you don't manage this, if you do nothing at all. I would beg to stop here. Yeah, thank you very much.
Thank you very much, Dr. Baguma, for that presentation on engagement of stakeholders. We can all appreciate that the community is the biggest stakeholder here, and among others. So I did not see a lot of questions coming in, but I'm sure members will have some issues to ask you at the end. I would like us to proceed to the last presenter, Dr. Francis Pebolo, who's going to look at other blood disorders in pregnancy.
Yeah, thank you.
Dr. Francis, over to you.
Thank you, Dr. Baifa. Are you getting me? Are you getting me?
Yeah, we can hear you.
Yes,
okay,
we get you.
Thank you. We have to discuss something small about other blood disorders in pregnancy. So of importance is that we need to look at the normal HB. Of course, Dr. Baifa gave a background of what a sickle cell, how a sickle cell can occur, what genes is normally affected. Normally, it's important to know that each of the hemoglobin has two globulin chains, and it has one pair of an alpha chain and then one pair of another non-alpha chain. The non-alpha chain can be gamma, it can be beta, it can be delta. In a normal adult, we have hemoglobin A, which has it's composing of almost up to 98%, containing 2 alpha chains and 2 beta chains bound together. And then in hemoglobin A2, we have about 2-3%, containing 2 alpha and then 2 delta chains. And then the hemoglobin F, which is the commonest hemoglobin in fetus. But of course, it can also persist in adulthood. That means it can also be present in a pregnant woman, composing 1%. This is just a picture to show you how a typical hemoglobin it is made up of. There's an IM group that you can see is actually projected out there, and then we have the globin chains. Of course, the alpha and then the beta bound together. And when these things are bound like this, they actually have very high affinity for oxygen. In a normal situation, this one will pick oxygen where there's high concentration of oxygen, and where there's low concentration of oxygen, it can be able to release an oxygen molecules, what we call the Bohr effect. If you look at other blood disorders that can occur in pregnancy, because we have two types. We have the disorders that are related to the amount of globulin chain that are produced, and then the ones that are related to the structural changes, like the hemoglobin S, which is in sickle cell disease that was already discussed by my colleague. And then you have other variants like the hemoglobin C and then the hemoglobin E as well. In hemoglobin C disease, you have lysine substituting for glutamic acid in the 6th position of the globulin chain, and that causes in a person who has homozygous states, that is, you have hemoglobin CC. That means that you develop mild chronic hemolysis, and you also develop some splenomegaly and jaundice. The heterozygous state, that of AC, is actually basically normal. These are people who present with normal, everything is normal. But if you have a C and then a sickle cell hemoglobin bound together, then you actually have a serious consequences. In thalassemia, I think most of my discussion will be around thalassemia. This results from defective globulin chain production. It can be alpha, beta, delta, or delta beta, then delta beta and gamma thalassemia. So of course, for public health important, we have only the alpha and the beta thalassemia. Of important is that we need to know that if you have excess unbound alpha or beta chains that are not bound to themselves, they are not actually paired together, they become insoluble in red cells, and this actually causes a lot of hemolysis, cellular damage, and then bit of hemolytic anemia, and then sometimes because of the hemolytic anemia, you end up having iron overload. In alpha thalassemia, is actually one of the most commonest inherited hemoglobin disorder that affects almost 5% of the world population. You realize that up to 5% of the world population are actually carrier, affecting the people who have pure alpha thalassemic syndromes, almost 1 million. And this affects a lot of sub-Saharan Africans, Mediterranean, and then the Middle East, and then the Indian subcontinent. If you look at this, actually this is a pic from a study that was done in Uganda. This study was meant particularly to look at how alpha thalassemia has effects. The people who have alpha thalassemic genes, how do they behave with malaria severity? You realize that the people who have alphas, it was done among 304 participants in Uganda here, and it shows that 22% of them, they already having some alleles that shows alpha thalassemic syndrome. So that means it's actually quite common. Probably we're not making diagnosis of this, but we have it in Uganda here. The appearance, the presentation depends on the number of genes deleted. If you delete a great number of genes, it actually will present with a severe form of it. If you delete all the genes in alpha thalassemia, you realize that the alpha is actually start forming early in the fetal life. So that means that you have the gamma genes binding to themselves, and this will present what we call Bart's hemoglobin. And this is actually thought to be incompatible with life. Most of these babies die in utero because of severe anemia, cardiomegaly, outdraft fetalis, and ultimately, of course, they will have to die. Sometimes they die early after delivery. They can cause a perinatal death But of course, of recent, it's important to know that with the advent of intrauterine transfusion, and then subsequent bone marrow transplant, some complete deletion of alpha genes may actually survive. The defect in beta genes bring a variable condition. They present with a variable presentations. If you have a beta node, that means that you have complete absence of production of beta globulin on the affected allele. Then beta plus and beta double plus is just varied presentations. The double plus means that you have very mild reduction. So that means these individuals are almost normal. But of course, there may be changes that we'll see later in the blood pictures. The classification, especially the beta thalassemia, which is as a clear classification, is that we have the old classification that talks about the major, the intermediate, and then the minor. Of course, related to the clinical management, a newer classification has been adopted that look at the transfusion dependent and then non-transfusion dependent beta thalassemia. The transfusion dependent, that means that you need really blood transfusion to manage their anemia or extramedullary hematophosis. The symptoms of thalassemia are varied and they are very unspecific. You might find some bone marrow, bone deformities, especially in the face. You may actually have dark urine, that's hemoglobinuria, maybe delayed growth and then development, and excessive tiredness and fatigue, and sometimes you present with the yellowing is just because of the jaundice that is coming after hemolysis, and then the anemia, the pallor. This is how you can differentiate a sickle cell disease and thalassemia. If you look at the clinical presentation, in sickle cell disease in a pregnant woman or a woman in reproductive age, most of them would have already undergone autosplenectomy. So they may actually do not have any evidence of splenomegaly. But in thalassemia, there's always present of splenomegaly. Red blood cell morphology, you find in sickle cell disease, most of the time you actually nomocytic, nomochromic anemia. And in thalassemia, the cells are slightly smaller and then they are a little bit pale. If you do HB electrophoresis, you find that in sickle cell disease, the A2, the hemoglobin A2 is between 2 to 4%, but you have a higher percentage in the thalassemia. How do we make a diagnosis in our lab? Normally you find altered red cell indices, especially microcytosis. I talked already about microcytic anemia, I talked about hypochromia. But this is very hard to differentiate between that and then iron deficiency anemia, because iron deficiency anemia definitely present with microcytic hypochromic anemia. And also it's hard for you to differentiate using just red cell indices to know that this is a beta, this is an alpha thalassemia. A specific methods that can be done, which I think is not widely available, and I have not used or seen it being used in our region here, probably hematologists probably around Kampala can use that, is high performance liquid chromatography. Or you can also use capillary zone electrophoresis that actually distinguish between the different thalassemia syndromes and then the carriers. This can also be used as a prenatal and also a postnatal diagnostic tool. If you need to type the specific genes that is affected, you can actually do a DNA analysis. We need also to look at fertility in people who have thalassemia. Normally, because of iron overload and then pituitary siderosis, many of these women who have thalassemia develop hypogonadism. So they might actually present to you with history of amenorrhea and then ultimately inability to conceive in up to 90% of them, especially those who are actually having major, the transfusion-dependent thalassemia. This starts early in life, in the first decades of life, and it's accelerated quite fast in the adolescence. The good news is that they have a very normal ovarian reserve, and a normal ovarian reserve means that they can actually, you can do superinduction and then maybe other methods of reproduction, and they can have a normal birth. How do we treat this? The transfusion-dependent thalassemia may actually need regular transfusion. There may be some chelators that you need to give to reduce the iron overload. You need to, in people who have gross splenomegaly, you may need actually to consider splenectomy. The daily folic acid is very important. And then these patients are also at risk of developing gallbladder. So it's important that if they have that, you may actually need to gallbladder stone. So they are actually more likely to have surgeries to remove gallstones. Genetic test and bone marrow transplant is another option, especially in the thalassemia, I mean, the alpha thalassemia when there is complete deletion of alpha genes. If you detect that in utero, you can actually do in utero transfusion, and then you can do a bone marrow transplant. That may be the future of that in Uganda. We still do not have that. Pregnancy management in especially transfusion-dependent thalassemia, you may need to actually be giving blood transfusion, and you may also need to manage the iron overload. The iron overload, you may need to monitor the serum ferritin levels. If there are red lines that shows that you're turning towards iron overload, you may actually need to give chelators. And it's important for you to know that the iron consumption, because of changes that occurs in pregnancy, actually increases. I mean, the blood consumption may actually increase in pregnancy because of changes of. There are complications that might occur when you have a thalassemic disease, maybe because of changes in the cardiac function, because of prolonged anemia that has occurred. We can also have risk of pregnancy-specific complications that are more likely to occur in a thalassemic mother. So it's important, if you have a thalassemic mother, you may need to have close monitoring for placental ischemic disease, placental abruption. They are more at risk of developing gestational hypertension, just like sickle cell disease that were already discussed by my colleagues. They are more likely to develop, the stones can be the gallstone, the kidney stones, and then bladder stones. And because of recurrent issues of stones and probably injuries to the urinary bladder, you're more likely to get a urinary tract infection, and probably because of anemia. There's risk of thrombosis, and this is almost like 4 times in a normal woman who do not have that. So it's important, if a woman is pregnant and is having thalassemia, these are women that need thromboprophylaxis. Thank you for madam.
Thank you very much, Dr. Pebalo, for that elaborate presentation on other blood disorders in pregnancy other than sickle cell disease. And he has explained in detail, especially thalassemias among our pregnant women. So he was our last presenter. So would like to move on to the question and answer session. We had some questions that were coming through the chats. And then we would also love to check uptake of knowledge from the webinar. So we have a couple of questions that will be relayed to members to check if we benefited from this session, yes or no. So dear panelists, we've been able to note some questions which came in along the way. To Oscar Ocaya, under case presentation, there's a question of why was the urgency of delivering this mother at 35 weeks of gestation? Was it 35? Why the urgency? Couldn't the team wait? What guided your decision to deliver her at that gestational age? Okay. And then the other question that came in was, there is need to clarify the dosing of magnesium sulfate. I think this was answered already in the charts. I think there's a mix-up between use of 4 grams versus 14 grams for the management of preeclampsia. This has been cleared. Dr. Ojara, to remind you of your question, how do you handle pre-pregnancy planning in the event that most pregnancies in Uganda are not planned, over 80%? And then also the other issue, how do we investigate iron overload individual? I think this has been answered in the chat if we follow closely by doing iron ferritin levels and then also iron binding capacity of blood. And then also how often should a sickle cell disease mother be seen during pregnancy at the ANC? The other question is, at what point do we resume hydroxyurea postpartum? Since you mentioned that it is transmitted through breast milk to the baby. The other question was the issue of how much fluid should these mothers be given. I think this has also been answered in the charts by Douglas. Fluid replacement is weight of the patient, the fluid deficit, and the clinical status of the patient. So it's not cast on, this is the amount that we give our mothers. So the other question that came was, how do we iron overload in case a patient? Members, please mute yourselves. Oh no, sorry. There are some members whose microphone is muted, and please mute yourselves, okay? Dr. Kumu from Arua Regional Hospital, you're going to tell us something on the new drug, on the drug that is being used for reduction of sickle cell crisis, a case of Arua Regional Referral Hospital in summary. And then Dr. Baguma, the other question that came to you was, what is the safety of hydroxyurea in children? And what is the major indication of hydroxyurea in children, as mentioned in your presentation? Then Dr. Pebalo, what is the most appropriate productive advice you'd give a mother with sickle cell disease in your clinic setting? And lastly is, what is the safety of PenV prophylaxis in pregnancy? Those are the questions that came through. So I would like to welcome the panelists to respond to them, and then we get other questions from participants. Thank you. So Dr. Chaya, over to you. You have only 2 minutes.
Thank you so much for the question. I think I'd even try to answer the question on the chat. The decision to do cesarean section was basically because she came with severe preeclampsia and she was at 35 weeks, and uncontrolled blood pressure was deemed the best option for her at that time. Thank you so much.
Okay, I hope that's clear. Let's move on to Dr. Ojara. Dr. Ojara, you have 3 minutes since your questions are many.
Thank you. I think there were a number of questions that were put. How do you do preconceptional counseling? I think this is why we are having this session. We have to do community education and awareness. So the people should understand that sickle cell is an heritable disease that we can plan better for pregnancy outcome since we know the risk. So we must inform the community so that they understand it. And serum fattening, best is doing the blood serum level should be within normal, not more than 300 milligrams. And then ferrous sulfate, yes, we would avoid to give it if the serum fattening is high, and that's why we insist that you have first to do serum fattening before you give someone ferrous sulfate. So practically, I would give on a folate. And then how would you monitor the ANC risk? I think on a monthly basis for routine, it's better. Now during COVID, we need a lot of modification. Probably you can call someone on a phone and ask them, so that giving them regimen for at least 3 months would be better. Because right now with the COVID pandemic problem, making someone traveling frequent to the facility is also a risk. So we have to plan this on individual basis, depending on the risk of the mother. And when do you allow them to stop hydroxyurea? You have to discuss. We are now saying a child is born and she is known to be having sickle cell disease. Start planning now. Don't wait when she again conceived. So issues of getting unplanned pregnancy in a sickler in this country, we should stop it. We should work against that so that we educate them and empower them. So that should be on our side. We must empower them. And then about low molecular weight heparin, when do you, for how long do you give it? For someone who had a normal vaginal delivery, we would probably give up to 10 days because the less risk, they will be mobile and they'll be moving. But for someone who have had up to, with a C-section, they have more potential risk with bedridden, we would probably prolong them up to 6 weeks. But in other protocol that I've shared and look around, in UK, they give it up to 6 weeks. Probably in this country, it's point for discussion that team has to decide, but I would think it would be safer if someone has potential risk, maybe issues of venous thromboembolism, we probably give them up to 6 weeks. That would be on my side. I would think about that. Volume, 60 ml per kilogram in 24 hours. That can be for you for controlling good hydration. So after calculating all the data deficit, you can work around that. Now the new agent Voltox that has been given to us, we want to see what is feasible for controlling pain and also improving hydration. Hydroxyurea from the randomized control study that has been done around the world, it's still proven very good drug. Maybe our colleague from Arwinyo can give us more news on this, that there are many other agents. But when you look at this particular anti-cancer drug, hydroxyurea, it has the power of hydrating the red blood cells, that there is improved turbidity, and also reducing cytoadherence, that it controls the vasopressive crisis. Now, in pregnancy, we are concerned, does this woman come with the severe pain or it has been controlled? If it is controlled, that's mean when you withdraw away out from hydroxyurea during the pregnancy time, you are able to manage her. And then once she has delivered, probably at appropriate time after the baby at least can survive other side of the weaning, then you can carefully reinitiate it. But of course, this is case by case. If she has acute chest syndrome, issues of stroke, I don't think you would think of continuing with breastfeeding up to 1 year. This is a case by case that you need to address it on your particular patient. Now, whether PNV is used as a prophylaxis, no, in this country, but in children is given. And now for women who are pregnant in the UK, I said this is what they do. They offer the protocol that all women who are pregnant are given penicillin. But in our country, we don't have a written protocol that we can talk about. Maybe from this discussion today, we can come up with understanding what we can do. And last, I think we look around on the question that was posed by Professor Moko on why the Caesar was done for this young girl under bilateral tubal ligation. Now, this is a girl that we've known in this hospital for over 15 years. She's actually one of a child that comes in and leaves the hospital, and the mother has always been very distressed. So this was through family counseling, family dialogue, and they chose and they opted for that option. And I think it was for our own safety because so many things has happened in our life, and that's why that decision was taken. Thank you so much for all your questions and participation. Back to you, Dr. Baifa. Dr. Baifa, are you on control?
Okay, sorry, I was muted by one of, I believe it was an error. Thank you very much for the brilliant responses, Dr. Ojara. Members, you can follow up the chat for some supplements from members that are participating in the webinar for clarifications. So we are going to move on to Dr. Your question was only one. What is the safety of hydroxyurea in children and what's the major indication? My pediatrician to be.
Thank you very much.
Over to you, Dr. Baguma.
Thank you very much, Dr. Baifa. I don't know whether I'm loud enough.
No.
But you can hear me.
Yes.
Okay. Majorly, hydroxyurea is indicated to reduce the frequency or the number of times a sickler gets crisis. So hydroxyurea is indicated in children above 2 years, preferably, and the dose is weight dependent and also age bracket dependent in most of the time, since the formulations are a little few. Then the other thing is that before we initiate hydroxyurea in children, we need to do some baseline investigations. Most importantly, renal function tests, liver function tests, and also to check the urine output of these children to make sure that the drug can be easily washed out of the system, since it has issues with renal toxicity and hepatotoxicity. Basically, that's it. One other thing that we need to talk about is its availability within certain situations and periods. Since the doses are not enough for everyone, these children are put on and off the medications as the drugs are available, since they're also expensive. Thank you very much.
Okay, thank you very much, Dr. Baguma. Over to you, Dr. Pebalo, so that we welcome questions from participants in the next 10 minutes before we have the closing. We want to stop at exactly 4 p.m. Dr. Pebalo, your question is, what is the most appropriate reproductive advice you would give a mother with sickle cell disease? Okay,
Thank
a
you,
woman
Dr.
with
Baifa.
sickle cell disease.
Thank you, Dr. Baifa. It's important that a mother who is in the reproductive age, who actually want to probably get pregnant, there should be some counseling that should be done. This depends on a number of factors. You need to know how many times they have actually had admission, probably how many times they have had blood transfusion or any other complications that are there. Probably you need to also look at the organ damage. So the advice that you give them should be tailored according to the person you're talking to. It's important to go through them, take them through what are the likely complications that might arise during the pregnancy. So you take them through what would pregnancy do on sickle cell disease and what would sickle cell disease do on the pregnancy. So you need to take them through so that when they are actually getting pregnant, they have an informed choice. But I think this should start way back. Someone raised an earlier question saying that most of the pregnancies are actually unplanned. But I think if these people are followed up, they normally have some way. They have a sickle cell clinic somewhere being followed up from. I think this kind of intervention need to start right away from the sickle cell clinic as they grow. We know many people who have sickle cell disease may not make it to the productive life, but because of the advent, the changes that are coming, the changes in the management of sickle cell disease, the new advent that's coming, many more people are actually reaching the productive age. And that means that we may need to get intervention that will start right away from the sickle cell clinic, and that should be done. Preconception counseling genetic testing is very important. You need to also talk to the partners. If they are both carriers and probably they have a child who is sickle, you need to take them through what are the risks that they will have a child who have sickle cell disease. If the mother is a sickler and probably the spouse is probably someone who is a carrier, you need to take them through the risk that they can actually solve. So all this would actually, it means that you're trying to give them an advice so that they make an informed decision. And then advice related to family planning and whatnot is also key, so that you reduce the risk of getting unplanned pregnancy. High-risk pregnancy tend to have high risk of getting a mortality or a morbidity. So if someone really wants to get pregnant, it's important that they need to plan. Thank you.
Oh, good. Thank you very much, Dr. Febalo, for that response. It is a case by case, like he said. And I think I would like to open the floor to not channel their questions through the chat. Okay, unmute yourself and ask your question. Okumo Richard Arua Regional Referral, unmute yourself, submit your question.
I'm unmuted.
Yes, Okumo, you're welcome.
Thank you very much, Dr. Baifa. Yeah, for Marua, we are fine. And I'm responding to the question. They asked about the new drug. So this new drug actually was approved in 2019 by the FDA. Though its availability in Uganda, I'm not sure, I've not seen it, but I became aware of it in 2019. It's a direct inhibitor of sickling, and unlike hydroxyurea, which does it indirectly by increasing the fetal hemoglobin levels, this one does it directly by inhibiting the polymerization of the abnormal sickle hemoglobin S. So by doing that, the red blood cells are going to be stable. They are not going to sickle. And we are going to have actually decreased viscosity of blood and all that. So with all this, you're going to see actually decrease in the incidence of the crisis. So this drug, by doing that, I think it is a better one. If we have it in Uganda, it would be actually good. And something good about it, it has a better safety profile, including pregnancy, unlike hydroxyurea. And it comes as tablets of 500 milligrams. So in the books, they prescribe it as you can give 1.5 grams per day to either prophylaxis to decrease the incidence of crisis in those who are getting recurrent crisis. So the costing, the amounts, I'm not aware because I've not seen it, but it's good to know this drug because I think it is something better. We can actually give it to pregnant mothers according to the safety profile. Thank you very much. Yes, over to you.
Dr. Baifa, the mic is back to you.
Jeremiah, over to you. Unmute yourself.
Thank you so much. Thank you so much. Thank you so much for the presentation. Still so much on hydro to know. I don't know how often should these children be taken for these blood tests, like the RFTs, you know, the CBCs, because previously I got to know something about how it reduces the kind of the body immunity, something like that. So I needed to know from the experts how often should these children be taken, you know, monitoring their acting. And then also, is there any relation between height? Thank you so much.
And what?
I was saying.
You're on and off.
My network must be very poor, but I was trying to say.
You your question, since you're breaking, it will be responded to. Jeremiah.
Okay, please.
Okay, let's
All
have
right,
Eddie.
right.
Eddie, unmute yourself.
Yeah, thank you very much, Doctor. My question goes to Dr. Ojara about the mode of delivery. Like most of the times when you find these patients, since there are very few, and the clinicians tend to decide for an emergency Caesar just to prevent the stress they go through in having a normal delivery. Would like be a gold standard for the delivery, mode of delivery? Thank you.
Dr. Ojara, have you got that question?
Now, we say for mode of delivery, in a normal obstetric case, if the mother has no any other warranting indication, you allow her to go to term and spontaneous labor onset. But if there are clear obstetric indication, then you may choose to induce her, or you may choose to do an elective Caesar. There must be justified obstetric indication. This is what we can do about them. So if she appears as an emergency for some non-obstetric indication, maybe she has severe preeclampsia or she has a fit with an abruptio, straight away, you know, this is an emergency, I will take her for elective Caesar. So mode of delivery, straightforward for a normal obstetric case, normal vaginal delivery should be spontaneous labor.
Okay, thank you. I hope you have got that. Thank you, Dr. Ojara. As normally as possible, unless indicated otherwise. Okay, I don't see any hands up. I saw whose hand up. It looks like it was by mistake. There are no any other from the charts. To summarize our session for today, we've been looking at management of sickle cell in pregnancy, and the key take-home messages have been, one of them is to have appropriate preconception care. And we can only achieve this if we are able to track these clients right from childhood through our sickle cell clinics, and then discuss with them their reproductive plans and all. In that way, we are able to have preconception care when they open to us on when they want to have babies. And then also the aspect of psychosocial counseling has come out clearly. We know very well these patients, those that have the, you know, that syndromic feature of sickle cell disease, they tend to undergo stigma. Some of them do not fail to get partners. There's a lot of stigma. So psychosocial counseling is key to allow them to accept them as people who can also reproduce and have healthy babies. And then the aspect of health education has come out clearly, both at community level and at facility level. We want to see that the community is aware of sickle cell disease. They're aware of the reproductive possibilities of these women, and then also how the hospitals can help them. So this will help with timely linkage of these people from the community to the facility. And when they come to the facility, we want to also educate them more to understand their condition. In this way, they will be able to make wise reproductive choices to reduce morbidity and mortality. We saw multidisciplinary aspect coming in clearly. It is a team way of management for mothers with sickle cell disease. It's not only the obstetrician, it's not only the pediatrician. So the ped is going to hand over to the obstetrician when she's pregnant. The hematologists are coming in, the pharmacists, to see that this mother quality of care to reduce morbidity and mortality. And then we've appreciated that in the intrapartum care, SVD, normal delivery, is the best mode of delivery and the safest for them to prevent complications of infections, DVT, postpartum hemorrhage, and all other complications that are associated with invasive delivery modes, C-section and instrumental delivery. We've also appreciated making sure that hydration status and oxygenation status of these mothers is kept good enough during the process of labor and throughout pregnancy to reduce sickle cell crisis and also reduce poor birth outcomes for both the mother and baby. Pain management has come out clearly. We've appreciated the regimens to use for these mothers, opioids as drugs of choice, and to minimize use of pethidine as a result of, since it causes, it may result into seizures as an effect in these mothers. So there is need to have appropriate clinical linkage within the hospital and appropriate referral of these sickle cell disease mothers from lower level units to tertiary centers to have better management. These aspects have come out clearly from our presenter. And then I must appreciate that this has been attended by a wide variety of participants from across the country. We've got input from Arua, we've got participation of Health Center for in Kasese. They've attended, which is a very good practice that would love that it is cascaded across the other health center 4s as well, and to include health center 3s as well, since these mothers, they are the first to see these mothers and they are the ones to refer these mothers to tertiary levels. End of my part, we've addressed a couple of questions, and be free to contact the Health Center for General Hospitals and regional referrals nearest them for further advice. And reading does not stop. We need to continue reading to get abreast with the updates on management of sickle cell in pregnancy. It's 3:56. We have 4 minutes to the end. I would like to hand over to the Secretariat to have the ceremony. Thank you very much, panelists from Acholi Sub-Region. We are very proud of you. Thank you.
Thank you very much, Dr. Baifa. Dr. Ruth Grace, the NASMEC Secretariat. I'll be taking over from Dr. Richard Kajimo. You have definitely concluded this wonderful webinar with all the details. So I would not like to delve into what you have said. However, extend a thank you note to the entire team of Gulu University and Lacor Hospital that came together on short notice to have this webinar done. I would like to appreciate the members wherever you are attending from in a different parts of the country. We appreciate you more for being able to join us on this road of knowledge gaining. And for further, as we are concluding 3 minutes to the end of time, we would like to kindly inform you that we have a webinar that is upcoming. It is a COVID webinar that came up due to the concerns of the NASMEC members, that's the National Safe Motherhood Committee, and the need that came from the doctors on guidance on how to manage pregnant mothers and babies with COVID-19. So please kindly be on the outlook. That will be on the 8th of July, which is next week on Thursday. For members that have questions about presentations, yes, we shall share the presentations with your emails, with email addresses shared. However, a kind reminder that in the chat, my colleague, Dr. Eladu, has shared a YouTube channel on which we upload all presentations. So in case any of you did miss the presentations from the previous weeks, you kindly find them uploaded on. Thank you very much, colleagues.